I want to thank the OncoAlert family and my friend Jill Morgan for inviting me this year to give you some updates on what is new in acute leukemias. For the interest of time, I will be giving you some updates from the ASH meeting 2025 that happened in December on acute myeloid leukemia with KMT2A rearrangement, AML with FLT3 mutation, AML with NPM1 mutation, and some updates on Philadelphia chromosome positive acute lymphoblastic leukemia and Philadelphia chromosome negative ALL. I will start by this study reported by Dr. Osman comparing intensive chemotherapy with FLAG-IDA to standard of care 3+7 in patients who have AML with KMT2A rearrangement. This is a large study, 217 patients with a newly diagnosed AML, younger patients, of course, as you might expect, receiving intensive chemotherapy, median age 41 years. Those were treated on 2 large randomized trials with either FLAG-IDA or 3+7 based chemotherapy. Overall, in the whole population, the rate of complete remission or complete remission with incomplete count recovery was 82% after induction, and it went up to 90% after cycle 2 of therapy. In the whole population, the 3-year overall survival was 43%. But then if we compare, as you can see in the first graph to the left, the outcomes or survival with the FLAG-IDA compared to 3+7, you can see almost double the survival, significant improvement in 3-year overall survival, 66% with FLAG-IDA compared to 37% with 3+7. Again, this is in patients who have AML with KMT2A rearrangement. The second curve shows us the risk of relapse. The cumulative incidence of relapse was higher with 3+7 compared to FLAG-IDA. And in the last curve, independently of chemotherapy, patients who achieved MRD negativity by flow cytometry at the end of cycle 2, they have better survival, 71% compared to 19% in those who remained MRD positive. This study, reported from MD Anderson Cancer Center by Dr. Kadia, described the outcomes of 22 patients with a newly diagnosed AML and KMT2 rearrangement who received the CLIA-based chemotherapy with or without Venetoclax. If we look, the rate of complete remission, CR, was 66% with CLIA and 94% with CLIA-VEN, telling us that the addition of Venetoclax improves the outcomes, improves the response rates in patients with KMT2A rearranged disease. So we should add Venetoclax in this group of patients. The rate of MRD negativity by flow cytometry was also significantly higher. 100% of the patients who responded achieved MRD negativity compared to 40% in those who did not receive Venetoclax. Most of the patients underwent a transplant. And again, although the response rates and the MRD negativity rates are high with CLIA or CLIA-VEN, most of the patients with KMT2A rearranged disease will eventually relapse and need to undergo transplant. The 2-year overall survival was also higher with CLIA-VEN, 81% compared to 50% with the CLIA alone. Shifting gears now to FLT3 mutated AML. This is a study also reported from MD Anderson by Dr. Goulart and Dr. Kadia, where they looked at 48 patients who received the CLIA-based chemotherapy with the addition of a FLT3 inhibitor. CLIA, as a reminder, it's a backbone chemotherapy composed of cladribine, which is given IV daily for 5 days in induction, idarubicin, which is given for 3 days during induction, and cytarabine, which is given at high dose for 5 days during induction. Patients received FLT3 inhibitor with either gilteritinib, 80 to 120 mg per day, or sorafenib, 400 mg twice daily. The rate of CR/CRi was 83%, and among responders, 88% achieved MRD negativity by PCR. The 8-week mortality was low, 2%, and 78% of the patients later went to receive a bone marrow transplant. As a reminder, up until now, most of the patients who have FLT3 mutation should undergo a bone marrow transplant, with the exception of a small subset of patients that achieve rapid and deep molecular remission by high sensitivity test at a sensitivity of 10 to the minus 5 or 10 to the minus 6, where transplant might be skipped. The 4-year overall survival was 62% overall, and as you can see here, higher with transplant compared to without transplant. As you can see in the second curve, patients who underwent transplant in green did better than those who did not undergo transplant in blue. The far right panel shows patients who are FLT3 positive, but stratify them by the presence or the absence of the NPM1 mutation. And as we know in AML, patients who have NPM1 mutation have generally a better prognosis. Therefore, patients who have NPM1 mutation have a 4-year survival of 73% compared to 53% in those who are NPM1 wild type. Another study also from MD Anderson led by Dr. Short and reported by Dr. Azevedo at ASH, looking into triplet therapy, azacitidine, venetoclax, and gilteritinib. This time we're shifting into low-intensity therapies for patients with FLT3 mutated AML. 30 patients were treated. As you can see, median age 71 years, again, older patients. They received azacitidine standard dosing for 7 days. Venetoclax and gilteritinib are given daily, continuously. But it is very important to perform a bone marrow biopsy at day 14 of therapy to look at the percentage of disease. In patients who achieve an aplastic bone marrow, who have a blast percentage less than 5% at day 14, can safely stop venetoclax and gilteritinib while awaiting for count recovery. Half of the patients, 47%, underwent a transplant in first remission, and 6 of them received post-transplant maintenance with a FLT3 inhibitor, which is becoming more and more standard practice. The median relapse-free survival was 23 months, almost 2 years, and the median survival was 29.7 months, almost 2 years and a half. The 3-year survival was 46%. If we can see, the rate of death in remission was 36%. This is, again, a group of older patients that could die from other infectious comorbidity or maybe from transplant-related complications. If we look at the bottom row, the relapse rate was 21% in patients who received the transplant compared to 50% in patients who did not receive transplant. And therefore, it is very important to send our patients with FLT3 mutated disease to transplant, even in some of the older age groups. Now we switch to a very exciting study, SAVE. This is a study led by Dr. Gus Issa from MD Anderson, where he looked at a triplet therapy with revumenib, a menin inhibitor, with low-intensity therapy, decitabine, and venetoclax in patients with AML who are newly diagnosed. 21 patients in total. 14 of them had NPM1 mutation, 6 had KMT2A rearrangement, and 1 patient had NUP98 rearrangement. The median age of this patient population was 70 years, again, older patients. The quarter of the patients had therapy-related AML. Very encouraging results. The overall response rate was 86%, complete remission 76%, and MRD negativity rate 86% in patients who are responders. In those who underwent NGS MRD testing for NPM1, all of them achieved NGS MRD negativity at the sensitivity of 10 to the minus 5 to 10 to the minus 6. The 12-month survival was 57%, and the 12-month EFS was 50%. If we look at the second graph, the duration of response at almost 1 year was close to 70%. Again, maybe NPM1 has a more favorable prognosis, but patients with KMT2A and NUP98 have a worse outcome, higher risk of relapse, and therefore all these treatments should be a bridge for allogeneic stem cell transplantation in this high-risk group of patients. Another triplet therapy by Dr. Issa for relapsed refractory AML with KMT2A rearrangement or NPM1 mutation is this combination of azacitidine, venetoclax, and ziftomenib, another menin inhibitor. 80 patients treated overall, 51 with NPM1 mutations, and not 29 with KMT2A rearrangement. Ziftomenib is given at 600 milligram per day in combination with azacitidine and venetoclax at standard dosing. Patients were pre-treated, median treatment number 1, ranging from 1 to 6. The CRC, the composite CR rate was 49% in patients with NPM1 and 22% in patients with KMT2A. The median survival was not reached in those with NPM1 mutation and was 5 months in those with KMT2A rearrangement. Previous studies have indeed shown that this ziftomenib has better efficacy and activity in NPM1 compared to KMT2A. We move from AML to ALL, Philadelphia positive, ponatinib and blinatumomab in newly diagnosed Ph positive ALL, a study led by Dr. Jabour from MD Anderson, presented by Dr. Goulart at the last ASH meeting. Total 88 patients so far, median age 50 years. 19% of them were after the age of 70 years. They received blinatumomab for a total of 4 courses. Blinatumomab is given 4 weeks on, 2 weeks off for a total of 5 courses. Since day one, patients are started on the 3rd generation tyrosine kinase inhibitor ponatinib at 30 milligram per day, which is reduced to 15 milligram per day once the patient achieves a complete molecular response and undetectable disease by PCR. All patients received 12 to 15 doses of intrathecal chemotherapy to prevent CNS relapses. 78% of the patients had P190 transcript and 20% had P210. After a median follow-up of almost 3 years, the survival, as you can see in the lower curve, was excellent. The 3 to 4 year survival rate was close to 90%. Only 2 patients underwent a transplant in this study. Very encouraging and excellent results in a high-risk disease where patients used to be transplanted almost universally. Now almost none of the patients, only 2% among 88 patients received the transplant. 11 relapses were observed, 5 in the bone marrow, 5 in the CNS, and 1 extramedullary. Most of the relapses are occurring in patients who have a white blood cell count above 70. So again, if you have a patient who presents to you with Ph positive ALL and white blood cell count above 70, this patient is at higher risk of relapse. You should do more intensive, you should do all the doses of intrathecal chemotherapy and maybe introduce 1 or 2 cycles of high-dose methotrexate and cytarabine to reduce the risk of CNS relapse. We shift the strategy now to hyper-CVAD, inotuzumab, followed by blinatumomab in Ph negative ALL this time, 75 patients treated. Younger patients, of course, we're giving them intensive chemotherapy, median age 33 years. Let me briefly remind you about this study. So patients receive 4 cycles of intensive chemotherapy, hyper-CVAD. During cycles 2 to 4, patients receive, in addition to hyper-CVAD or in addition to high-dose methotrexate and cytarabine, they would receive inotuzumab. And after these 4 cycles of chemo, they would receive 4 cycles of blinatumomab and then go to receive maintenance treatment with POMP, 3 cycles of POMP followed by 1 cycle of blinatumomab, and we would repeat this for a total of 15 cycles. The CR rate was universal 100%, MRD negativity 95% by flow cytometry, 79% by NGS. The 60-day mortality was 0%. As you can see in the top middle curve, the 4-year EFS rate with the addition of inotuzumab was 91%. The 4-year overall survival rate with the addition of inotuzumab was also 100%. And even in high-risk patients, the 4-year survival was 85%. So again, the incorporation of chemo and immune therapy is significantly improving the outcomes in a newly diagnosed Ph negative ALL with 100% survival with inotuzumab, blinatumomab, and hyper-CVAD. And the last regimen that I'm going to talk about is the dose-dense mini-CVD inotuzumab, blinatumomab. This is a regimen pioneered by Dr. Kintarjian from MD Anderson and Dr. Jabour as well. 25 patients treated, median age 39 years. This is, again, a group of patients who have relapsed refractory, heavily pretreated ALL, who receive chemotherapy with inotuzumab, with blinatumomab very early on as a condensed or dose-dense fashion. This has been reported last year. So response rates 100%, MRD negativity 95% by NGS, 2-year overall survival 77%, and those who received consolidation treatment with a bone marrow transplant or CAR T cells had better outcomes, 90 to 100% survival compared to only 50% survival in those who did not receive any consolidation therapy. And here I want to conclude by the practice changing data for 2025. We had an FDA approval for revumenib and ziftomenib, two menin inhibitors, as monotherapy for patients with relapsed refractory acute myeloid leukemia with NPM1 mutation. What is exciting, what to look for in 2026, combination therapies now of menin inhibitor with either low intensity or intensive chemotherapy in AML in the frontline and relapsed refractory settings. Subcutaneous blinatumomab, I did not show the data now, but exciting data is coming in 2026 showing encouraging safety and efficacy in relapsed refractory Philadelphia chromosome negative acute lymphoblastic leukemia. Thank you very much and looking forward to seeing you in the OncoAlert Colloquium 2027.